Hello, my friend. Welcome to my show Chronicles of a Loner RN, and thank you for listening. My name's Ritika. I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today, we'll be talking about psychosis. So this will be the first part of my little mini-series on mental health, different aspects of mental health, because mental health is such a big sort of area of health that I want to sort of deep dive into it one by one. And as a disclaimer, all names, numbers, results will be altered to protect the privacy of the patients that I discuss in these episodes. So, this will be a speed run sort of edition because I should be asleep for night shift, but here I am recording this for you guys. But we'll get into the story. About maybe 3-4 weeks ago. No. Yeah, about 3 weeks ago now. We had a man in the department that came in with psychotic symptoms, and he had a past history of Parkinson's. I was on the morning shift. This happened on the night shift. At about 6 o'clock in the morning, he had a code grey where he was escalating. I think his wife was called in to calm him down. Then she left, and then at about 6:30, he got up and he cracked it. He walked. So he was staying just across the hall from the first staff base. He walked over, picked up our ANUM's computers, and started throwing them at people. Throwing them at the nurses, throwing it at the nurse in charge. He called a code black. We restrained him, sedated him, and I don't think he came out of restraints until it was time to go up to the ward, just because of how quickly he could deteriorate. But the reason that he started throwing stuff at us was that he thought that we were going to kill him, which obviously isn't true because we like to help people. not really murderers, but yeah. Unfortunately, people with psychosis and their delusions, you can't drill in sense into them, which is unfortunate. But anyway, we put him into 4-point mechanical restraints, and then we gave him chemical restraints as well. So we gave him droperidol, which is an antipsychotic, which usually knocks people out pretty good, but it didn't touch this guy, which is unfortunate. I later learned that day that Parkinson's can actually cause psychosis or psychotic symptoms. So let's discuss. I just want to preface, though, that I'm not an expert or even qualified as a mental health nurse. I'm qualified to provide emergency nursing care to mental health patients. And unfortunately for us and the patients, that is essentially babysitting and medicating them to keep them as calm and comfortable as possible in the chaotic ED while they wait for a mental health bed. This mini-series, though, will just be mental health from the perspective of an ED nurse, not a mental health nurse, because their scope of practice and our scope of practice are very, very different. Let's continue. What is psychosis? So psychosis is a mental condition that affects the person's ability to differentiate reality from delusion. Many people often see it as like they're talking to the walls, or what we call responding to internal stimuli. So whether they can hear something, they can see something that nobody else can see, or they have these sort of paranoid feelings that like somebody is out to kill them, like this man. That's quite probably the most common sort of delusion, is that somebody is out to harm them. And no matter how many times you say, no, you're safe here, they don't believe you. Perception is the biggest thing that affects people with psychosis. It just sort of, they just lose perception. They can, if you think about like that one track mind, it's sort of like that. They can only think about the thing that is irrationally worrying them. And nothing you do or say will really get that off their mind. Um, because of this, psychosis can actually be quite dangerous for us as members of the healthcare workers and to themselves. Because if, say, they're responding to internal stimuli, so if they can hear a voice telling them to either harm themselves or harm someone else, sometimes that voice is so loud it can drown out us, the real voices. And they tend to listen to the voice to try and get it to go away. Or if they're seeing something, same difference really. This can sort of persuade them to do things they wouldn't normally do, like harming themselves, harming other people, being aggressive, stuff like that. Though there is a difference between being just a bad person and psychosis, because psychosis is a medical condition. They can come out of it a completely different person. Being a not so nice person, well, that's just a part of your personality. It's just, usually being a not so nice person will be distinct from patients. Like when you meet someone that's floridly psychotic, they may be a bit rude, but it's, how do I say this? It's not you they're rude at, if you get what I mean. Like, they don't want, I don't know, I'm just going to stop there because I don't know where that thought train was going. But a lot of people with psychosis, because they can't distinguish reality from their delusions, we tend to tell or say that they do not have decision-making capacity. This means that they are not of sound mind to adequately take care of their own health. When this happens, we usually have to put patients on what's called an assessment order or a varied treatment order. We'll get into the specifics next week. But by law, we have to somewhat detain them. They're not allowed to leave the hospital. Usually not everybody gets restrained. That's like last resort. For our safety and the patient's own safety. But when they don't have decision-making capacity, they are given a piece of paper and a statement of rights and are told by law they cannot leave the hospital until a psychiatrist comes to assess them. This is just to protect them, because if they're not in their right state of mind, letting them back out into the community can be extremely dangerous. But the causes of psychosis, there's two really different causes. You can have organic causes of psychosis and drug-induced psychosis. I feel like drug-induced psychosis is quite self-explanatory. Drugs like ice, meth, stimulants, like MDMA, stuff like that, or like psychedelics can cause psychosis, where usually once the effect of the drug wears off, they'll usually go back to normal. It's the organic causes of psychosis that are a bit of a worry. These are usually a result of schizoaffective disorders, so like schizophrenia. Some other conditions include bipolar affective disorder. When people become manic, they can become psychotic as well. Yeah. That's really it. We'll get into, when I say organic, it's not, shouldn't be mistaken for an organic cause for a mental illness. And by that, I mean there is actual neurology that are causing mental health symptoms. By organic, I just mean not drug-induced. But we'll talk about another organic sort of cause for psychosis, and that's Parkinson's. So Parkinson's disease is in basic of basic terms, I did like a project on this in year 9. It's a neurodegenerative disorder that primarily affects movement. It works by reducing the amount of dopamine in the bloodstream, which is a neurotransmitter, and therefore fine motor movements aren't as precise, and this is why you see the tremoring. And as the condition progresses, it gets worse. It's not just fine motor movements that are impacted, it's major motor movements. Even just moving tends to be a struggle. But apart from tremors, it can lead to involuntary movements, stiffness, and, as I found out a few days ago, is associated with mental health conditions and certain types of dementia. Now, I knew about the dementia one. But there's no cure for Parkinson's. Another person, actually, you might know that has Parkinson's, if you've watched Back to the Future, is Michael J. Fox. He's very vocal about his Parkinson's. But yeah, there's no cure, but there are treatments to hopefully slow the progression of the condition. This is by supplementing dopamine. It's given multiple times a day to combat the low numbers already in the bloodstream. And this is usually, you may have heard of it, Kinsin, or Matopar, or levodopa, carbidopa combinations. If you've ever looked after someone with Parkinson's and that's on Matopar or Kinsin, you know that Parkinson's meds need to be given like on a military grade schedule. Like it can't be late. This is because it proves ineffective, or too much time between doses allows for worsening symptoms to arise, even if that delay is just 1 or 2 hours. So giving Parkinson's meds on time, paramount. So like when I was saying that I knew a patient with Parkinson's and dementia, I'll talk about another case. A patient I looked after on the ward when I was a grad. Unfortunately, she had Parkinson's and Lewy body dementia. She was only in her mid-50s, so she was really young. But she was, her quality of life was so poor. She was bedbound, extremely stiff, full of cyst, couldn't feed herself, couldn't wash herself, couldn't move herself, and was often just sort of there, not really taking anything in, not responding to us. You couldn't really get a conversation out of her, except when she had some moments of lucidity. Now, this is when, in the midst of the stiffness and the anger and the all other emotions that we had to deal with, there'd be periods of time, very, very short, fleeting periods of time, where she would be herself. You could speak to her, she would tell you her wants, her needs, and often she'd break down crying from the realization that her quality of life is so poor. I only really saw her husband twice, I reckon. Saw her carers more often than her husband. I don't think I ever saw her kids. Maybe I saw her kids once on her birthday. She stayed with us, I think, nearly a year before getting transferred out when I think she got COVID, just after I left the ward. She was a lovely patient to look after. One of my fondest sort of patients that I think about when I think about my awfully traumatic time on the ward. um, but that's the dementia combo. It is quite common for people with Parkinson's to also get a type of dementia. Lewy body is usually the other one. I think Robin Williams had his, I think, misdiagnosed with Parkinson's from what I gather on the internet, but he actually had Lewy body dementia, or the other way around. But either way, they're linked, the two of them. How though? I'm not too sure. But let's get back to, let's call him Code Black Man. Add to our list of men. We've got Stroke Man, Asthma Man, Flu Man, Diabetes Man, and now Code Grey Man. Cool. Code Black Man. Yep. So the psychosis element of Parkinson's disease is actually like a recognized condition, subcondition, or complication of Parkinson's. It's called Parkinson's disease psychosis. It's actually quite a common complication. About 20 to 60% of people with Parkinson's will get it at least once. And this is come about through a multitude of different sort of factors. The medications can cause like a surge of dopamine that can lead to psychotic symptoms. The dementia, Parkinson's combo can lead to delirium, which is an increased risk for psychosis. But determining the cause of Parkinson's disease psychosis is actually quite difficult. But the way you fix it is you fix the underlying issues. You don't really fix the psychosis itself. Usually there's a medical component to their sort of picture that you can fix that will resolve the psychosis. So in this case, fixing electrolytes, shifting their medication schedule or changing their medications, plus adding some antipsychotics into the mix like olanzapine may fix it. But I don't know what happened with this man. He went up to the ward, and I'm sure he would have been a lovely patient up there. No co-grays at all, I'm sure. Before I did say this was going to be a speed run, but before I knock off, just want to discuss the difference between delirium and psychosis, because a lot of symptoms overlap, but they are very distinct conditions. Delirium is a state of acute, this is coming from Google, by the way, like a word for word verbatim. Delirium is a state of acute confusion and altered awareness, often caused by a medical issue, and is characterized by fluctuating symptoms and a clouded sensorium. Never heard that one before. Psychosis is a symptom of various mental or physical conditions involving loss of contact with reality, often hallucinations and delusions. Now, while both can involve hallucinations and disorganized thinking, delirium is typically easily fixable and acute. So most common people with delirium are old people with UTIs because they get so confused. But lots of people can get delirium. Even young people can get delirium. It's a pretty scary condition. Mimics a lot of the symptoms of psychosis. They become confused. They don't know where they are. They get a bit combative because they don't know who you are. They don't know what you're doing to them. They don't know what's happening. But psychosis is specifically responding to like internal stimuli. So they can see or hear something that we can't see. Or they have this fixed delusion that is not based in reality. Psychosis is usually fixed through antipsychotics and sometimes electroshock therapy. I think it's called electroconvulsive therapy, ECT. I actually have a good story about ECT and the time I actually got to witness one, which I'm very grateful for to this day. Not in this episode though. I think I've got an episode lined up in a few weeks where we'll talk about another case study I saw on the ward with this. I'll give you a peek now. This man who, just for the clarity, he was convinced that Jesus had told him to stop eating and drinking for 60 days. Otherwise, Jesus was going to kill him. He was very set that this is what had happened. So he stopped eating. And he developed a starvation ketosis. Before Diabetes Man and the highest ketones of 7 I'd seen, this was the highest ketones I'd seen at 5 point something when he first came in. And obviously, we struggled to feed him for a while until we got it under control. And I'll discuss a bit more about the paperwork in this specific case as well next week when we talk about AOs, assessment orders, treatment orders, varied treatment orders, community treatment orders, temporary treatment orders, and stuff like that, and the Mental Health and Wellbeing Act. And then I'll talk about it in depth and what we did over the course of 2-3 months, or 60 days, 2 months, to try and get him to eat and trying to get him to let go of these delusions. And in case you don't listen to that one, or you listen to that one but you don't listen to this one, I'll give you a spoiler. It didn't work. This man made it the full 60 days that Jesus told him to starve. He made it. It actually is a really, really decent feat, to be honest, now that I haven't looked after him in over 2 years. And I'll save the funny story about his first meal. Because after the 60 days was over, he's like, okay, I can eat now. 60 days is done. We're like, damn. Should have just let him wait the 60 days. But yeah, I'll talk about that in a later episode. It's going to be a good episode, guys. So you should listen to it. But anyway, that's me done for today. I'm sorry it was a bit of a rushed one. But like I said, I'm not a mental health nurse. I'm an emergency nurse that has to essentially babysit, for lack of a better term, mental health patients until they can go where they need to go to get the care that they need, which is unfortunate, but that's just the way the healthcare system works. So these sort of mini episodes on, like I said, the last time I did a mini episode, it wasn't very mini, but I promise these ones are going to be a bit minier because I can't really give you all that much information apart from what I have experienced myself. But anyway, that wraps us. That was awful. That wraps up this episode of my show, Chronicles of a Learner RN. I certainly have learnt a lot today. I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.